This video presentation and its accompanying materials are copyrighted by the American Association for Respiratory Care, AARC. Any public display, sale, copy, or distribution of the video or materials may only be undertaken with the prior written consent of the AARC. As a registered participant, you are authorized to duplicate course materials for this program for each participant viewing at your facility. This presentation and accompanying materials can be used by staff within the institution, but cannot be resold, distributed, or displayed for profit. Copyright 2018, all rights reserved. The following is a presentation of the American Association for Respiratory Care. Welcome to Current Topics in Respiratory Care. Today's topic is Meeting the Challenge of COPD Care in the U.S. Meilan Han MD, MS, is an Associate Professor of Medicine in the Division of Pulmonary and Critical Care at the University of Michigan. Dr. Han discloses relationships with Boehringer Ingelheim, GlaxoSmithKline, Sanofian, AstraZeneca, and Novartis.
Good morning. It's early. It's such a pleasure to be here, and I can't tell you what an incredible honor it is for me to be giving the Tom Petty Memorial Lecture. I think for those of you who were familiar with all of his work and everything he did, not only was he a brilliant physiologist, but one of the main things that he did was to help us understand how important multidisciplinary care for patients really is. And so that's largely what I'm going to be talking about today. We have a lot of patients with COPD who have some truly basic and truly just fundamental challenges to getting basic COPD care. And so we can talk about guidelines, but if patients really can't get their basic needs met, then we have a lot of work to do. So for the last several years, I have been doing a lot of work to truly try to understand, sort of at the ground level, what the problems are with respect to caring for COPD patients here in the U.S. I've been working with the COPD Foundation, I've been working with the American Lung Association, and also put together a fairly large perspective for Lancet Respiratory Medicine, which was published 2 years ago. But in going through this process, I spoke with patients, primary care physicians, respiratory therapists, nurses, people from the pharmaceutical industry, the National Institutes of Health, to really try to understand what's working, what's not working, and what we can do better. And so today what I'm going to share with you are sort of this series of perspectives from each of these stakeholders to try to understand really what our role is in trying to improve care for patients with COPD. So one of the biggest problems we have is that COPD is underdiagnosed. I actually was supposed to be on consults today. And the last patient I saw before I ran off to the airport yesterday was a gentleman who had just undergone cardiac bypass surgery and was quite hypoxic after the procedure. And they were having a really hard time managing him and understanding why he was so hypoxic. It turns out that right before surgery was done, someone had done pulmonary function testing on this individual. He'd never had it done before. His FEV1 was around 30-something% predicted. He actually had fairly severe COPD that had never been diagnosed. He'd never been on any kind of treatment, and here we were now, post-surgery, trying to help this man come off of oxygen. So this is really a huge problem. Of approximately 30 million individuals in the US that have COPD, about half of those are undiagnosed. The problems are fairly wide-ranging with respect to lack of patient awareness and perhaps talking to their physician enough about symptoms as opposed to blowing them off, but also from the physician side of things, not recognizing symptoms in early phases, not asking patients the right questions, and not ordering enough spirometry. COPD is actually a costly condition. This is why groups such as Medicare are suddenly much more focused on COPD than they have been in the past. In terms of direct costs, about $27 billion a year. But of those, COPD exacerbations actually account for a huge proportion of the overall cost. So trying to identify patients and doing what we can to prevent exacerbations really needs to be a key goal of care. I actually have an interest in women and lung disease, and actually recently just got back from the National Institutes of Health where they held a workshop actually on women and lung disease, and so I couldn't help sharing a little bit of information with respect to women and COPD while I was here with you this morning. So it turns out not only are patients with COPD getting younger, but also if we look at that group of individuals under 65, it's also disproportionately female. So as we think about the changing demographics for COPD, it is increasingly going to be a woman under 65 as opposed to a man over 65, which is I think what we typically think about. One of the other reasons why this concerns me is that in general, patients with COPD tend to be socioeconomically challenged. And if we look at the breakdown, particularly in terms of annual income, it's women in particular that are at or below the poverty level. And we think about all of the resources it takes to pay for medications and even to have money for transportation and figure out how to navigate our rather complex healthcare system. It's these patients I worry about, who I think are potentially the most vulnerable. Women also carry a higher burden, just globally, of disease. Prevalence for COPD in women now actually outstrips men in the US. More women are dying of COPD, and more women are hospitalized. So this is the changing face of COPD that we're going to be seeing both in the outpatient setting as well as the hospital. So I mentioned that today we're going to talk about a series of perspectives. I worked with the COPD Foundation to go through their 360 blog and to try to look at some of the comments. What are patients saying? What are caregivers saying about the challenges they're facing on a daily basis? And here are just some snippets of some of the comments that we found. I was told I needed pulmonary rehab, but there is none in my area. I think this is something that we're all too well familiar with. Here's another one. My medications worked well for years, but after my insurance quit covering my medications and I was switched, my breathing worsened and I had to purchase the original ones out of pocket. And a lot of times the patient finds out about this just because a letter they get in the mail that their medications have been switched, or they show up to their pharmacy to get their refill expecting to get what they know how to use and someone trained them on, and all of a sudden it's a totally different medication. So patients report a lot of problems. They report problems with access to pharmacotherapy, problems with access to pulmonary rehab. We know due to changes in reimbursement structures, a lot of pulmonary rehab facilities have unfortunately closed their doors, and this has caused huge problems with access, particularly in rural areas. Patients also report problems with lack of disease state education, not knowing where to get education. Physicians may not have time to provide that education. One of the other things, though, that I have to admit I had never really thought about was the emotional impact of delayed diagnosis. So I mentioned we have about 15 million patients who are undiagnosed. By the time they finally get that diagnosis, many of them are actually fairly advanced, as was the gentleman I was telling you about earlier. So those patients now, for the rest of their lives, are forced to sit there and sort of think about, well, if I had known earlier, maybe I would have done something differently. Maybe I would have made those lifestyle modifications. Maybe I would have been more serious about stopping smoking. And so that's something that they sort of, that guilt that they sort of end up living with for the rest of their lives. When we think about caregivers, this is a group of individuals perhaps we don't talk about enough. But particularly as patients get into their later stages, there's a lot of burden with respect to travel to doctor's appointments, helping arrange medications. What do we do about oxygen? Patients are in the hospital less. The average length of stay for a patient with a COPD exacerbation, I think, is somewhere under 2 days now. So really, this is relying on the family to take care, over a large portion of the care that used to occur in the hospital. And we really don't currently have good support systems for our caregivers. As I mentioned earlier, COPD is a disease of economic disparity as well as geographic disparity. So this graph in green shows where most of the COPD patients are. And if you think about where that is in the US, I mean, that's a huge strip sort of right through Appalachia. So we have a lot of patients with COPD in rural areas. And it's in the rural areas where we don't have rehab. It's the rural areas where we don't have specialists and pulmonologists to try to take care of these patients. So that poses a real problem. We also have a significant number of patients with COPD at or just barely above the poverty level. So again, this poses problems with respect to access and navigating the healthcare system. Turns out, and I think this is actually somewhat staggering because we know we spend billions of dollars on COPD care, 11.5% of total COPD expenditures end up being out-of-pocket costs for our patients. Now, the biggest cause of costs are inpatient stays. Fortunately, most patients have some kind of insurance, or at least disaster insurance, to cover the majority of hospital stays. What ends up, I think, for many patients being the hugest problem are out-of-pocket costs, particularly for prescriptions. So for individuals who spend or spent more than 10% of their annual income on health care, on average, those patients were spending about $2,500 a year just on prescriptions. So what is the consequence of this? Well, I think this is some really interesting information on adherence to medications by disease state. So if we look at the other big killers, the other big chronic diseases that we have in the US, diabetes, hypertension, cardiovascular disease, adherence to medications for COPD is at the bottom of the barrel. And there is data to suggest that even what we might consider a fairly modest $20 monthly copay can actually result in non-adherence. If you think about it, many of our patients with COPD actually have a lot of comorbidities. So we're not just asking them to pay for their respiratory medication, we're also asking them to pay for heart medication and diabetes medication. And so for a variety of reasons, perhaps cost, perhaps the sense that, well, I only need it when I'm symptomatic, adherence for COPD medications remains quite low. It actually turns out that if we can actually improve patient access to pharmacotherapy, we actually reduce overall healthcare costs. So this graph shows what happened to overall healthcare spending in the first year that the Medicare drug benefit program rolled out. And it actually caused a reduction, a $1,000 reduction in overall healthcare spending. I think all too often we treat healthcare in silos. So we've got the hospital has their kind of profit and loss balance sheet, and the pharmacy has their profit and loss balance sheet, and we've got to figure out how to break down these silos and look at care from a more global perspective. I think there are some really unique things, unfortunately, about Medicare that impact patients with COPD in a way that perhaps other diseases are not impacted, because we've got Medicare Part B covering respiratory supplies and durable medical equipment. Then we've got Medicare Part D covering medications. And so a lot of times, and I know we've all seen this, you have patients with very severe disease. They have no Part D or very poor Part D, and they end up on nebulized treatments. I have many patients I've evaluated, for instance, for lung transplant that are just on only whatever we can get through nebulized medications because it's all that they can actually afford. One of the things that actually has improved a little bit is availability of smoking cessation therapies, pharmacotherapies in particular. With the Affordable Care Act, there were provisions that were made to try to improve, both through Medicare and through Medicaid, patient access. But I would say still globally, we probably do not have enough patients who have access to tools to help them quit smoking cessation. So this graph shows the percent of Medicaid smokers who are receiving smoking cessation prescriptions in 2011. And at the high end of the spectrum, the darkest blue, we have people between 11.5 and 25.5% down to the lowest end of the spectrum, which is under about 7%. But if you think about it, even the quote-unquote high end of the spectrum here is not all that high. So we have a few pockets where under a quarter of patients are actually receiving pharmacotherapy, and then everywhere else it's just worse. So I think we could be doing a lot better. All right, so what about primary care? What's going on there? Well, they have a lot of challenges as well. There's a lot of barriers to COPD diagnosis, both from the patient side and from the physician side. So from the patient side, I think we need to, as a respiratory care community, do a better job about public awareness for respiratory disease. Patients don't know that having symptoms of shortness of breath, cough, and wheeze is not normal. Patients may not even know what COPD is, and they don't know that they need to go in and ask their doctor for spirometry. Many have never even heard of that. I think if we could do a better job educating the public, then they could go in and talk to their doctors and say, hey, you gave me that diagnosis of COPD, but have I had spirometry? I need to know how bad it is. We recently opened up a transitions of care clinic at the University of Michigan, where we receive patients that have been hospitalized for a COPD exacerbation, and our goal is to get them into clinic within 7 to 14 days to try to optimize care and get them out. I would say, roughly speaking, a third of the patients that I have seen in this clinic don't even have COPD. I get the spirometry, and I've got all sorts of other diagnoses: paralyzed diaphragms, interstitial lung disease, but not COPD. So we've got a big problem with respect to both underdiagnosis and misdiagnosis. On the physician side of things, we've got things like time limitations. They may not be sure the best way to screen. They may not know the best way to ask questions, and they may be really uncomfortable with ordering spirometry. And if they even do get it, they may be uncomfortable with figuring out how to interpret it. I think many of you recently probably have seen the recent U.S. Preventive Services Task Force that was published in 2016 that again came out against population-based screening for COPD. And unfortunately, I think for many, the takeaway message has been, oh, well, let's just not worry about it. You know, there's no guilt, no harm, no foul. I don't have to worry about it. They're telling me it doesn't matter. And I really think we have to be careful. I think that is the wrong message. We know that we have things that work. Smoking cessation works. That improves lung function. We know we can help patients feel better. We know we can stop exacerbations, or at least reduce them. And so I think the message needs to be, how do we do a better job of finding these patients? What are the tools that we need to use, the case-finding tools, to identify the high-risk patients, to identify those who should undergo spirometry? So this is actually interesting. I didn't actually know this before I did this sort of systematic review recently, but actually less than 10% of all ambulatory pulmonary care is actually provided by pulmonary specialists. It turns out there just aren't enough of us. So the number of pulmonologists in the US has actually stayed static since 1997. I actually did not know that. And so this graph actually shows you, this is a ratio of COPD patients to pulmonologists. And at the best end of the spectrum, you might have for instance, one COPD patient to say 202 to 1. But at the worst end of the spectrum, it's over in the lightest blue, it's over 6,000. In the white, there's actually none. So as you can see, there actually are huge swaths of the country, particularly in the middle, where there are either none or perhaps one pulmonologist in a very wide area. So we have to figure out better ways to get these patients access to specialty care. There are multiple health systems that are looking at things like telehealth, but then we also need to do a better job about equipping our primary care physicians to care for COPD better. There's actually no data, interestingly, to suggest that pulmonologists are actually any better than primary care physicians at least adhering to guidelines. But they do tend to be more aggressive at prescribing inhaled medications and oxygen, and are, I think this is probably key, more likely to be aware and refer patients to pulmonary rehab. So again, this is where I think the onus is on us to educate our primary care colleagues about the benefits of rehab, to make sure that they're aware, they know where the programs are, and know how to get patients referred. When we think about the kinds of things that patients are prescribed, particularly with respect to pharmacotherapy, it turns out, unfortunately, overall, we're actually not doing a very good job. Overall evidence suggests that 30 to 70% of patients actually get no therapy or suboptimal treatment. So if you look, this is broken down by commercial insurance versus Medicare, but in general, we have somewhere between 50 and 60-something% of patients who are actually getting no treatment whatsoever. When I say no treatment, I mean not even a short-acting beta agonist. And then as you can see, that the rest of the splits sort of go off, but everything is somewhere under around 10%. So we have a huge swath of the patient population that are getting very little therapy for their COPD. We face challenges on the inpatient side of things as well. We have a wide range of providers, from hospitalists to intensivists, that might be taking care of patients on the inpatient side. We know that there are 1 million COPD patients who are admitted annually, and about 20% of those are actually readmitted within approximately a month. This was a study done by Peter Lindenauer that was published in 2006, and he looked at the percentage of patients that sort of received ideal care. And the number of patients that sort of received all ideal care and none of the non-ideal care was actually overall quite low. Some of the other challenges that we have is that a lot of, for instance, our hospitalists or our nurses have not received COPD-specific training, and we don't have good care coordination in many of our hospitals between members of the team, including our team, nursing, physicians, and then also care coordination trying to, as we move patients out of the hospital. We know that the hospital readmissions for COPD are now definitely on Medicare's radar screen. So the hospital readmission reduction program, which now includes COPD as well as several other conditions, was recently instituted. And specifically, Medicare is looking at 30-day readmissions after a hospitalization for COPD. It turns out, rather frustratingly, that it doesn't even matter why the patients were readmitted, but any readmission within 30 days counts towards the hospital penalty. Multiple hospital systems, I'm sure many of you are aware of a lot of the different studies that have been done, are really trying to figure out how to improve these numbers, what can be done. There's a lot of people looking at inpatient and transition care teams, many of them led by respiratory therapy, getting patients into pulmonary rehabilitation sooner. I think it's interesting to think about the fact that we are not the only country struggling with these kinds of issues and struggling with thinking about how to best care for patients with COPD. It turns out in the United Kingdom, a big push for them from the National Health Service has not been so much readmissions as it is trying to get patients from going to the emergency room in the first place. It's the second most common cause of ED visits in the UK, and so they're looking at how they can better improve care overall. I think one of the good things about the HRRP shedding some light on COPD is that it's suddenly getting attention that it never received before. So I think that is perhaps one of the good things. On the other side of things, though, I think it's also frustrating in that we're still trying to figure out the best way to really try to tackle this problem. So what are the reasons behind causes of high 30-day readmission rates? And I think they're myriad. Exacerbations may not be fully resolved. As I mentioned, the length of stay, because hospitals are increasingly crunched for beds and costs. Patients are being discharged sooner. poor communication between the inpatient and the outpatient teams. There's a lot of things that can sort of get lost in the transition. If you think about patients, for instance, that are on one set of medications in the hospital because that formulary is very specific to the hospital, and then they get home and they're on a whole different set of medications at home because their outpatient insurance is different, and then they end up coming back into clinic with a huge bag of a variety of inhalers, and they end up taking multiple things that they probably shouldn't, and other things that they should be on are completely missed. So this is a challenge. Getting patients set up for home oxygen or other equipment that they need is a challenge. And in many cases, we don't have a good plan in place for patients with respect to what should they do, should they start having symptoms of an exacerbation. Well, I think the focus on readmission is great. I think what we really need to do, though, is to focus on how can we care for patients better globally. How do we prevent the first admission? How can we provide better kind of baseline ambulatory care for patients with COPD? One of the challenges is that when we look at why patients who are admitted for a COPD exacerbation are readmitted, it turns out only about 20% of the time is it actually related to, or 20 to 30% of the time, is it actually related to COPD. The rest of the time, it's other stuff, heart failure, psychiatric issues, in this case, GI problems. So this also suggests that just better global care for these patients as soon as they get out of the hospital should hopefully help. I wanted to mention that the Society for Hospital Medicine has actually developed something they call Project Boost, which some of you may be familiar with. And it really sort of breaks down all the things that can go wrong for a patient once they get admitted to getting transitioned and why they may ultimately get readmitted, and does provide some implementation tools for the inpatient hospital teams with respect to how to better coordinate care and how to improve these transitions. As I mentioned, and as I'm sure many of you are aware, I wanted to mention this study, but there are many others that have looked at RT-led inpatient care coordination teams. And many of these programs have actually been quite successful, not only in reducing readmissions for COPD, but also in reducing all-cause readmissions. I've been working on trying to spearhead something similar at our university. I can tell you from my own personal experience, at least at a university hospital, trying to get anything done system-wide is not easy. There's a lot of red tape, but one of the things that I have been able to do is to at least try to implement an alert list where we have a lead respiratory therapist for the hospital. He gets the alert list of all the patients with COPD that have been admitted, and we try to do at least one episode of targeted RT education before the patients leave to make sure that they understand their medications and are set up for oxygen and whatever it is that they might need at home. So pulmonary rehab, as I mentioned, is unfortunately grossly underutilized, I think, but we know that the benefits are huge in terms of improving symptoms, quality of life, exercise capacity, and for many of our patients, this is really a home for them. It provides a good social environment. Many of our patients end up staying in the maintenance phase and develop friendships and support. So this is such a great adjunct of care for many of our patients, but we just aren't getting enough patients in, and overall, I think use of pulmonary rehab is not what it should be in the country. There are a lot of challenges with respect to either lack of awareness, lack of referrals, and as I mentioned earlier, I think all of you are acutely aware of some of the challenges with respect to reimbursement that unfortunately have led to the closure of a lot of freestanding facilities that were located, I think in particular, in more rural areas. While I think many of the rehabs associated with larger hospitals have stayed open, this is in part due to this requirement for having supervising physicians on site, which is very difficult for programs perhaps in more rural areas or freestanding operations to actually be able to deliver. So we've got some challenges with respect to figuring out how to better deliver pulmonary rehab and increase access for patients. This may end up being changes in legislation, which I know the ARC has been very involved with. It may be exploring other routes to pulmonary rehab, such as non-traditional electronic or kind of telehealth type programs. So what about the payer perspective? I actually spent some time in doing this perspective in interviewing different health systems. So I spoke to Kaiser, I spoke to Geisinger, I spoke to representatives from Blue Cross, Blue Shield, in trying to understand what health systems and insurance companies, what are the challenges from their perspective, what are the initiatives that they're trying to put in place. So places like Kaiser, places like Geisinger, who particularly at some of the institutions are really out on the forefront of trying to figure out how do we better coordinate care, and in many instances through RT-led teams. Places like Blue Cross Blue Shield are also kind of pushing from the other side to try to get more coordinated care, not just for COPD, but for chronic care conditions in general. So I think many of you have heard of this concept of patient-centered medical homes, which try to coordinate care across multiple practitioners. There are several key components for a group to consider themselves a patient-centered medical home. If they kind of meet these components, then they can get extra care coordination and performance-based payments from the insurance system. And I know that there are kind of pockets of pilot programs like this all over the country. As I mentioned, CMS has enacted the Hospital Readmissions Reduction Program, as well as a Bundled Payments for Care initiative. Again, all of us as health systems kind of struggle through this. It's not always easy, and there are many demonstration projects, unfortunately, that have actually failed. I have a good friend, Mark Dransfield, for instance, at the University of Alabama, and he actually worked on a demonstration project with CMS where there was a huge influx of money to develop care teams that would follow up with the patients afterwards, after a COPD admission. And while patient satisfaction improved, there was actually no change in readmissions. So again, I think part of the problem is that it's a little bit too little too late, right? It's great to focus on how we can improve care in the hospital and afterwards, but I think overall we need to think about how we can globally improve care for our COPD patients. Just a little word about the pharma perspective. So we know that we've got a lot of inhaled medications in particular for COPD, but I think we as care providers and our patients would all argue that we could still be doing better yet. We still have high mortality from COPD. Many of our patients are still quite symptomatic, despite having stopped smoking, despite having the best treatments. I think increasingly, as we see new drugs developed, as the new drugs come out on the market for COPD, you're going to increasingly see fewer drugs that would potentially be suitable for all patients, and increasingly you're going to see drugs that are very specifically targeted for very specific subgroups of patients. So, for instance, roflumilast or Daliresp is only indicated in patients with chronic bronchitis and frequent exacerbations. Right now, several IL-5 inhibitors, mepolizumab and benralizumab, are being tested in COPD, but again, these are only for patients who have eosinophilia. And so I think increasingly we're going to have more narrow inclusion criteria as we get more specific for understanding the heterogeneity implicit to COPD. We're going to see phenotype-specific treatments for COPD. One of the challenges from a pharma perspective are the extremely high costs of drug development. I think in the kind of current era, I think it's close to $20 billion to get a new drug to market. Payers also, so the pharmaceutical companies have to think about what the payers want. And the payers increasingly want not just to know that this drug improves pulmonary function, but that it actually impacts outcomes and will help reduce their overall costs. So they want, kind of this longer-term, real-world outcomes data, which is then kind of pushed back on the pharmaceutical companies to think, how can we actually design kind of more real-life studies that would actually convince payers that the high costs of developing this drug and then marketing the drug and selling the drug are actually worth it. My hope is that we will continue to see drug development and we'll continue to see new drugs come out for our patients because it's clearly needed. So I do spend a lot of my time doing COPD research and have quite a few NIH funded projects. But one of the things that I think is truly staggering is the disconnect between disease burden and the amount of money that's spent on funding COPD research in the US. So essentially this is a graph of kind of disease burden versus dollars spent. As you can see, there is in that red circle is COPD, which is sitting very grossly off the line. So almost every other condition, the amount of money that we've put forward to try to research it, whether it's AIDS or cancer, kind of globally meets the number of people who have the disease and the morbidity and mortality associated with it, except for COPD. Now, fortunately, I can tell you at least this year things are changing. The NIH actually just refunded 2 very large initiatives for COPD, including there's a study called the SPROMIC study and a study called COPD Gene, and each study I think is approximately a $30 million initiative. But overall, COPD spending still, I think, pales in comparison. So that's, I think, one of the huge problems that we have. So I'm going to spend my last few minutes here talking a bit about what I think is good news. And this is the COPD National Action Plan that was actually released, first announced at the American Thoracic Society meeting in May. But this is a project that has been going on for the last several years. The NIH, in combination with the COPD Foundation, gathered a large group of stakeholders. They sent out a series of questions and got internet-based feedback. About 2 years ago, they held a town hall meeting where, again, stakeholders were invited to participate. They broke out into focus groups, tried to understand what the problems were, and then what would the next steps be that are crucial to seeing success. I will say that from our as a respiratory care community, it is important to know, however, that there is no funding that is attached to this. So the work is really not done. The work is really only beginning. What this is an outline of the work that needs to be done. And I think all of us can participate in a different way, and I'm going to go walk through this if you haven't seen it and kind of highlight where I think we can all perhaps participate, but sort of at a global level, at an advocacy level, at a grassroots level, it's still imperative upon all of us to reach out to our senators to try to figure out how to get funding for this proposal, because like I said, there is actually no funding. And I have to say just from a public awareness standpoint, when we did the press release in May, I was heartbroken, as were many of the individuals that helped to put this together, that the media pickup for this was almost non-existent, really. And so it's clear that we have a lot of work to do to try to engage the public and to help the public and the news media actually care about this disease. I think one of the challenges that we have is that unfortunately COPD is associated with a lot of stigma. So we have a group of patients that are socioeconomically advantaged and they live in rural areas, and they feel like, well, I have this disease that maybe it's my fault, I caused this. So we have a group of patients that really are not out there standing up for themselves, perhaps in the same way that other patient groups do with other chronic diseases. And so I think it's our job as a respiratory care community to help those patients find their voice. so that we can really raise the level of awareness on a national level. So this National Action Plan is really the first step, but it's really only a blueprint. The onus is on us to actually breathe life into this plan. So there are actually 5 different buckets, 5 different large overarching goals that kind of relate to each of the different stakeholders. And so I'm going to go through those one by one. So the first focuses on patients. So goal 1 of the COPD National Action Plan is to empower people with COPD, their families and caregivers to recognize and reduce the burden of COPD. And I've highlighted here just in orange, I thought a couple of areas where individuals in this audience and the ARC perhaps might be key players in this. So one of the things that we have to do is to improve just kind of on a public level and also within primary care, just disease awareness. Far too many patients don't even know what COPD is. They don't know to go in, for instance, and to ask for spirometry. We also need to also work on developing. There's a lot of stuff that's out there, but further figure out how to develop educational materials and support systems, both for our patients and particularly for our caregivers. All right, the second goal of the National Action Plan is to improve the prevention, diagnosis, treatment, and management of COPD by improving the quality of care delivered across the healthcare spectrum. So clearly this is an area where respiratory care is going to be sort of a pillar here, and has been, but needs to continue to be. So we need to try to work with our outpatient clinics to figure out how to improve COPD detection, care, and treatment. As I mentioned, I have a transitions of care clinic. Unfortunately, trying to figure out how to fund respiratory care in the outpatient setting, I think, continues to be challenging. I have fortunately somehow managed to convince the healthcare system, at least for right now, that I really need a respiratory therapist with me in the clinic, and I can't tell you just how amazing that is for me to be able to get some real-time help in the clinic, whether it's assessing need for NIPBV or oxygen or whatever it is. It's so valuable for me, and I feel so fortunate that at least for right now they're willing to fund that. But trying to figure out how to fund that on a more continuing basis for everyone, I think, is incredibly important. Help work with our primary care and again outpatient facilities to try to figure out how to find these patients with COPD, how to better provide COPD education in the clinic. And again, I think this is an area where respiratory therapy could be truly key to that. We know that they're already able to provide that, for instance, in pulmonary rehab, but again, a lot of our patients aren't making it there. So that's a challenge as well. Goal 3, collect, analyze, report, and disseminate COPD-related public health data that drive change and track progress. So this is kind of both a bit of a research imperative, but sort of at the public health level. How can we continue to track where these patients are, and to get that into the information into the hands of, for instance, legislators and people that can actually make a difference. So goal 4, this also sort of extends into the research realm. Increase and sustain research to better understand the prevention, pathogenesis, diagnosis, treatment, and management of COPD. So there's a lot of things that go into this research realm, but I think one of the areas where, again, respiratory therapy could be key is helping us figuring out how to design and test novel approaches for better implementation of case-finding strategies. How do we within the community find the patients with COPD? How do we best bring them to light? How do we get them in for spirometry and treatment? And finally, this really, I think, is a call to action for everyone. How do we take this and translate national policy, education, and program recommendations into research and public health care actions? I know that AARC has an active advocacy arm, but again, I think it's not going to be just for the lobbyists in Washington necessarily. I really think there needs to be a a ground roots push on all of our community leaders, our local and state level legislators to improve awareness and to get funding into the National Action Plan. So where do I see things going? As I mentioned, we can spend a lot of time thinking about the ideal guidelines, and actually I'm on GOLD and I've helped with the COPD Foundation guidelines as well, but that's all, I think, sort of intellectual pontificating if our patients can't actually get the medications that we'd like them to have. If they can't get to rehab that they really need to be, if they can't get access to respiratory therapy. So again, I think if there's any one take-home message, it's trying to figure out both at a local and national level how we can improve patient access. I think by doing that and improving care at sort of the ground level, that ultimately both admissions and readmissions will ultimately be impacted. And I think, sort of speaking to one of the kind of pioneering areas for Dr. Petty, is that we need to think more about interdisciplinary, multidisciplinary teams, both in the inpatient setting and in the outpatient setting. So this is one of my favorite quotes. Alan Kay is a rather famous computer scientist from the US, and he said that the best way to predict the future is to invent it. So I challenge all of you to think about in your own, think about where you sit from your perspective in your own institution, in your own practice. What would make things better? Envision your perfect future. Just what is your perfect future with the 360 perspective that you have where you're sitting at your own institution, and then figure out a way to achieve it. Thank you.